The left side temporal bone CT shows presence of soft tissue in the posterior mesotympanum in this patient with left-sided chronic otitis media. One can see anteriorly pneumatization in the middle ear towards the protympanum. However, the posterior mesotympanum appears to be totally opacified with presence of soft tissue, which is difficult to categorize on the CT as to whether it is epithelium or cholesteatoma or granulation tissue. As we can also see on these axial sections, the soft tissue is merely there anteriorly, laterally to the ossicles in the attic and not medially. So we begin here the endoscopic approach towards this left-sided ear surgery for tympanoplasty. As we do the minor suction, we see this patient already has had a lot of polypoidal and granulation tissue in the preoperative period and purulent discharge, which grew pseudomonas on the cultures. She has had 2 weeks of culture-appropriate antibiotics as well as topical medicines. And this is now the picture post that. So we begin with elevating our canal skin flaps in a standard manner. So for the initial primary incision, we are using the standard circular knife that we use in middle ear surgery. The key point here is to give an incision deep right onto the bone, because otherwise you will not be able to elevate the flap well ahead. We will take the incision slightly anterior to 6 o'clock inferiorly and just about 12 o'clock superiorly. It has to be borne in mind that the posterior superior canal skin is often thick, as we are used to encountering that in standard post-oral incision. However, in a totally transcanal approach, we might need a few strokes that are right on the bone to be able to create a plane for comfortable flap elevation. An appropriate local anesthesia is very important in endoscopic ear surgery, because otherwise even a minimal amount of bleeding would soak our endoscopes and compromise vision. And now we use an endoscopic specific instrument, that is a suction elevator, to gradually elevate the canal skin from the bone. As a precaution, we keep the suction to less than 50% of the normal to avoid tearing the thin canal skin here. Suction is most oftenly the most common reason for flap tears. So one has to take the time to elevate the canal skin. In the preoperative examination, we could not see any annulus, so we categorize this as a marginal perforation with presence of granulation tissue and with a possibility of epithelium, which has to be explored during the surgery. There is a severe conductive hearing loss in this patient. And as you see that the mastoid was clear on the CT, and so was the medial attic, we chose the completely endoscopic approach for this patient. The one can see now the annulus inferiorly at least. And we go medial to the annulus now to elevate the tympanomeatal flap with just a slight vision of the chorda tympani. So one must take care to elevate the entire flap in toto to avoid flap tears. We can see a small flap tear inferiorly that is lateral to the annulus. Most likely that should sit back on the canal wall nicely in the end. And as we see, we are taking utmost care to see that we elevate the entire canal skin with the tympanomeatal flap in toto to avoid missing onto any epithelium or gross disease that goes inside the posterior mesotympanic recesses. Now we resort to a sickle knife to gradually just tease off the tympanomeatal flap and sharply dissect any mucosal adhesions that could compromise our flap elevation. You could see this is already the incus, long process. And so posterior inferiorly, we still have some canal skin to raise. You can see a little hump due to which it takes a little bit time. In a standard endoral or a postoral microscopic approach, this hump would surely need drilling to be able to see medial to it. And immediately what we can see as we go deeper is that the incus is already eroded. We can see the long process already eroded. The lenticular process is not there. And there is no contact between the incus and the stapes. So again, the inferior part of the tympanomeatal flap is yet to be elevated, and as you see, almost the entire posterior mesotympanum is filled with the polypoidal granulation tissue that has to be removed, as well as closely inspected for any evidence of squamous epithelium. We can already see the stapedius tendon and the pyramid. So use a little small cotton ball for some temporary hemostasis, as well as to gently elevate the canal skin inferiorly even further. We see that with slump hemostasis, we already see that we do not see any evidence of any squamous epithelium as yet. What we observe is just granulation tissue and some polypoidal middle ear mucosa. And as you probably see in one note, even this kind of tissue in the absence of squamous epithelium is good enough to cause ossicular erosion. So now we elevate and we push this flap superiorly, slightly more anteriorly to the level of the malleus handle. Since the perforation does not involve the malleus, we would avoid bearing it. And definitely what we desire in this patient is to examine the medial attic very carefully to be able to again be sure that there is no squamous epithelium medial to this eroded ossicle, that is the incus. So what we do is first we remove some bit or most of the posterior mesotympanic soft tissue, that is the polypoidal mucosa, for disease clearance as well as for biopsy specimens. This has to be sent just to exclude any granulomatous disease such as tuberculosis. And as a practice, we also send some tissue for culture. Now we are taking an angular cup forceps to just clear some more mucosa from the posterior inferior region, the diseased mucosa, and so that we can see the healthy epithelium. And all this excess mucosa that we are removing will be sent in divided portions for culture as well as histopathology. Now, as we put our tympanomeatal flap back, we can see that this is the perforation that we are playing with. Anteriorly, you can still see some diseased edematous middle ear mucosa, though no epithelium. So we would just freshen the margins anteriorly, generously. And also clear this excess and diseased mucosa, which was already harboring bacterial infection. Now comes the part of cleaning up of the stapes. Now, in this patient, one has to understand that if we are very sure that there is no squamous epithelium, then we just need to have a gross debridement of the stapes and not to the extent that we rock the stapes too much. So we just use a sharp instrument like a sickle knife to gradually peel off the excess diseased mucosa from the stapedius tendon and the stapes head, and trying to not cause too much or excessive rocking movements of the foot plate region. The eroded incus, of course, we'll remove. Also, because the fact that we want to be very sure that the medial attic is free of disease and does not harbor any kind of grossly diseased mucosa or squamous epithelium. We can start seeing the fallopian canal almost immediately medial to the incus long process. Also to notice the fact that there is slight retraction in the anterior drum as well, which we need to cautiously elevate the anterior remnant of the tympanic membrane to create a space for our future graft, which would certainly be full thickness cartilage in this kind of situation. Now what we'll do is we just do a little bit of curating to be able to conclusively see and examine the posterior superior region. Also, that slight curating would help us extract the incus more carefully, because if we try to remove the incus within a very small space, that could possibly traumatize the stapes. So we use a curved needle or a curved pick to very slowly mobilize the incus from its bed, to pull it downwards slowly, and again trying to not use any strong force because that could dislocate the stapes. Once the incus is free, we remove it. Since this is a patient who had active Pseudomonas infection, we would not be using the autologous incus in this situation. We would be only using the cartilage directly on the stapes head for reconstruction. Now, some bit of excess redundant diseased mucosa from the posterior mesotympanum can also be cleared. The promontory is already seen. And what seems to be reassuring is that as of now, we do not see any squamous epithelium in the middle ear. We can see the fallopian canal that is intact, and some a little bit of excess mucosa or excess diseased mucosa from the stapes being cleared. To whatever extent it can be safely cleared. One may or may not also use lasers for this kind of step to denude the stapes more, but from a practical standpoint, it may not be required. So we use a very fine microforceps to remove the last very bits of the excess mucosa over the stapes head. Now this has to be done very delicately from posterior to anterior in the direction of the stapedius. And now post the same, you can see that the medial attic looks quite okay. The fallopian canal is in front, so is the processus cochleariformis. The malleus is still there. And now it comes down to the grafting. This is a wonderful view of the middle ear that we get through an endoscope without any significant drilling or curettage. And as you can see, the posterior mesotympanum, both superiorly and inferiorly, is very well visible as compared to microscopy. So for posterior mesotympanic diseases, I think endoscopic surgery is a great tool. So again, as we see that we are using a very fine microforceps to just sort of in the end bare the stapedius tendon and the stapes head. This is to check the undersurface of the malleus head to see if there's any gross disease left here. There's not. There's just some excess mucosa which can be left behind. So now as we prepare our cartilage graft, we would just put some small gel foam patties in the middle ear to achieve hemostasis while we initiate grafting. This is a small perichondrium that is taken from the tragus. So this we will be taking it medial to the anterior tympanic membrane remnant. So in case of some difficulty, one could use two hands by letting an assistant hold the endoscope, while the lead surgeon can use two instruments as well to place the graft anteriorly, or sometimes with a sickle knife it might just happen normally like such. So the thick perichondrium graft has already gone medial to the anterior tympanic membrane remnant. The endoscope also helps us to see in the recesses that there should be no part of it lateral to the TM remnant, so that no squamous epithelium is buried anywhere inside the middle ear. Now as we lift it, we have seen that this part is done. Now all we would require is to place a full thickness cartilage shield graft over the stapes head directly as a piece of graft. And this cartilage graft has perichondrium attached on the lateral side, the side that faces the canal, and is bare medially. Now once that is done, we replace the canal skin, tympanomeatal flap, and as you see that our perforation is well covered. Some little bit of bone is bared on the posterior superior canal wall, but that should be that should epithelize reasonably fast. We check once again for the integrity of the flap and the graft, that they are well opposed, in contact with each other nicely, snugly, and not moving and loose from anywhere. And any amount of loose epithelium can be placed over the bone, where the bone is bare. And as you see, that the whole assembly appears to be quite snug. Post this, you would just use some dry gel foam patties to place on the edges, first of all, of the graft and tympanomeatal flap junction, as well as in the anterior recesses. Now, gel foam has not to be placed to force it medially, but just to be kept gently over, first of all, the intersection of the graft and the tympanomeatal flap, as well as in the anterior recesses, so that it forms a nice sort of a firm seal for the first few weeks after surgery.